Thank you very much. Yes, perfect. It was lovely for me also. Meet somebody who is Padma Shri.
Academic session.
Yeah.
Let's proceed with the academic session. And let's welcome our first speaker of the day, Professor Dr. Ashish Verma, Department of Radio Diagnosis, IMS BHU, who will be sharing insights on the topic Precision Ultrasound in Thyroid Cancer.
पीपीटी आपकी
वो पीडीएफ है एक पीडीएफ
जस्ट अ सेकंड पीपीटी को शेयर करता है इसको नहीं शेयर कर रहा
है स्क्रीन शेयर कर दो ना
नहीं एक्चुअली पीपीटी को शेयर करना है ना सर
इसको बंद कर दो बस ये ठीक है अब तो क्या इसको मैक्सिमाइज कर दो नहीं नहीं इस पे इसको कर दो यहाँ से
फुल स्क्रीन यहाँ पे नहीं है एक्चुअली ये लेआउट अलग है इसलिए नहीं आ रहा सर इतना चल रहा है
we'll do it like this only So thank you, ladies and gentlemen, and I thank Apex Hospital, Dr. Ankita, for inviting me here for this talk. And I first start by congratulating all of you for this achievement. I think it is a very notable achievement by this hospital as well as for our city. And this is a very useful therapy which is being initiated in this hospital. And I think I'll keep it very basic so that everybody understands that what is the role of imaging, especially because thyroid is a very superficial organ. So I think the imaging of thyroid begins essentially with a thyroid ultrasound only. I think we all agree with that. And when it begins essentially with thyroid sonography only. And most of the time what my clinical experience is that the lesions in thyroid are usually diagnosed when we are doing sonography of neck for some unrelated cause also. So many times the patient would come for a carotid Doppler. The patient would come for evaluation of neck lymph nodes. So many times the patient would be just having lymph nodes in the neck because of some other cause. Maybe it's a tubercular node or a lymphoma node or something. And we do a sonography and we find that there is something in the thyroid. And then we are in a fix that what is the nature of the lesion. So I think the role of nuclear medicine is definitely prime. The thyroid scan, when we were students at that time, we also used to study that thyroid scan has to be done to basically decide that whether it is a malignant lesion, a benign lesion, a malignant lesion on the background of a thyroid which is functioning, a thyroid which is not functioning, a lesion which is hyperactive or not, and that the cold nodule and hot nodule thing. So in that scenario, when we all are conscious that thyroid scan, that is the nuclear imaging scan, is the one which is going to finally decide what is the role of sonography. So it is the initial role in detection, and then 2 in risk stratification. So as you must have heard in your inauguration also that this is a therapy which is required for treatment of thyroid, but there so many situations will arise in which there will be a nodule and we will not be able to decide that what is the cumulative risk of this nodule turning out to be a malignant one. So in these scenarios, how do we decide that it's a malignant nodule just based on the imaging features so that we can go ahead with the therapy? So the clinical context in which a nodule, we find a nodule and we do a thyroid ultrasound are pretty standardized. Like I mentioned, one is the palpable nodule definitely, and then goiter. So by goiter I mean just an enlargement of thyroid, and then you have a multinodular goiter in which there are multiple nodules in the thyroid. Lymph nodes, I think in our clinical practice, most of the time the patient presents with multiple enlarged lymph nodes, whether it is a thyroid lesion or not. History of familial thyroid cancer, that is another very important indication in which we get patients for sonography of neck to just see that, to screen the thyroid, whether there is a malignancy or not, or whether there is a nodule or not. I shouldn't be using the term malignancy on ultrasound only. Then patients of some syndromes in which one knows that there can be a malignancy or a nodule in thyroid, like multiple endocrine neoplasia. And then if there has been a irradiation due to some unrelated cause to the neck during the childhood or any period in the life. So all these are pretty standardized indications for which the patients come to us for neck sonography. And we know that most of the cancers, so here I am talking of the cancers only, not of the nodules, because most of the nodules that we have in thyroid, they turn out to be benign only. But of the cancers, those which are malignant, most would be papillary cancers, and papillary cancers we know are pretty nasty. They would have, initially they would have metastasis nearby, and if they are so nasty in the sense that they are very aggressive, but good in the sense that if they are picked up at a right time, if they are suspected at a right time and they are treated, then we can contain the lesion also. I think वो आपने Zoom पे किया था इसलिए. So that is why we should have a basic idea about this distribution, and then there are rarer things like the medullary carcinoma, lymphoma, all those things, but the main ones are the papillary carcinoma of thyroid. So when I talk of ultrasound, when we were students, when we were residents at that time, ultrasound would essentially mean a B mode ultrasound only, in which a grayscale image would be generated, and you would just look at the image and sort of based on the morphological feature decide that whether it is a benign nodule or the features are drifting towards a malignant. But now it's not only the B mode sonography, it is also the It's not only the B mode sonography, we also have the luxury of doing a Doppler sonography, in which we are able to see the flow of the lesion of the native thyroid as well as of the lesion, and then we can compare what is the status of the flow in the lesion as compared to the native thyroid. And then now a third dimension has come in, which is the ultrasound elastography. So it is something like a virtual palpation, in which a clinician usually palpates the thyroid and he tries to feel that how soft or how firm or how elastic the lesion is. So elastography is essentially the same thing, in which we give a shock wave to the nodule and then we receive back what has been reflected, so that we can decide what is the status of fibrosis, cellularity, etc. in the nodule. So all these put together now, so as opposed to the earlier days when ultrasound meant B mode only, now it is Doppler and elastography also along with the B mode. So that was about the investigation. Now when we see a nodule, so there is something known as ACR TIRADS, which was made by the American College of Radiology, and TIRADS is the Thyroid Imaging Reporting and Data System. So like you have in breast, similarly in thyroid also, this is a risk stratification system. So this is not for diagnosis. When a patient comes to your couch and you put a probe on the neck of the patient and you find that there is a nodule, your responsibility starts from there of giving a possibility of what are the odds of this lesion, what are the percentage chances of this lesion to be a malignant or benign, because the moment you give a nodule in your report, the patient will also see, and that is the moment from which his or her anxiety will start. So it is the role of a radiologist to give a reassurance to the patient that what are the odds of this lesion turning out to be malignant, and even if it is looking like a malignant, you can tell the patient to get it evaluated quickly so that the outcome is beneficial and it is in the favor of the patient. So these are the points which we see when we get a lesion in the thyroid. That is the composition, the inside of the lesion. I'll describe one by one. The echogenicity of the lesion, whether it looks black or whether it looks gray or whether it looks entirely black or white. So that is the echogenicity, the shape of the lesion, the margins of the lesion, and the echogenic foci. Within the lesion, if you have any areas of heterogeneity, any specific areas which are very bright, we call them echogenic foci. Now each are given specific points, as you see over here. So each property, we assess the lesion under the heading of each of the properties and we give a certain number of points. And these are finally added up to give a TIRADS score, and based on that TIRADS score, we decide whether it is a malignancy. It's likely to be a malignant lesion or likely to be an entirely benign lesion. So that's pretty simple. I think if once we get used to doing it, it is not very difficult. So that is what I meant by composition. Now here we see that there is a lesion which is entirely black from within. So I call it a cystic or anechoic lesion, and it is a benign nodule. And on elastography, we will see a cool blue color in this. So that means that there is a lesion which is a balloon-like lesion, a cyst, which is entirely filled up of water from inside. I'm using the term water in a very layman's terminology. I don't know how many of you are actually into doing a thyroid sonography, so that's why I'm using a very layman terminology. That it's a balloon kind of a lesion in which water is filled inside. If there is a lesion which is looking cystic as well as some solid areas are there, we will give it a higher score, and it is entirely solid, we will give it the highest score. So on a scale of 0, 1 and 2, as you can see over here. So this particular property is given some marks. Next is the echogenicity. So once we have seen that there is a lesion which is solid, we decide that how much solid it is, whether it is solid to the extent of being very close to cyst, water-like content, or it is solid to the extent of being entirely solid, being some cellularity or solid tissue inside it. And again we give it a point of 0 to 3. So this is the second feature which we study. Then the shape of the lesion. So like any lesion, we would like to see the shape, whether it is a well-defined lesion, whether it is wider than taller or whether it is taller than wider. So when I say taller than wider, so in the image we see over here, if the dimension on side-to-side dimension is more, that means the lesion is going along the planes. Tissue, it is respecting the tissue planes. But if it is growing across the tissue plane, then that's a nasty feature. So we give it a higher. So here you see that it's either 0 or 3. So if a lesion which is growing against the tissue plane, that would essentially mean that it is not respecting the normal anatomical boundaries, and therefore it's a nasty lesion. Margins, again, if it's a very smooth, well-defined lesion, then we'll give the least point, we'll give 0, because that means that the lesion is contained within itself. If the surgeon wants, he or she can bring out the lesion also. But if it's very irregular, then we'll give higher point. And if we see apertly that the lesion is going out of its capsule and going into the soft tissue plane, then we'll give it the highest point. So here you see that smooth lesion are 0, but extrathyroid extension is 3. So this is the fourth feature that we assess. And then the echogenic foci. So as in the breast lesions, we see that those who are of you are radiography students, you would agree that we look for microcalcification in breast. Similarly, we look for microcalcification in thyroid also, because we know that these dystrophic calcific foci are indicators of malignancy. So we look for these microcalcifications. We look for macrocalcifications also, but microcalcification, as you see here, would be given higher points, as opposed to macrocalcification, which will be given lower points. So, and then peripheral eggshell-like calcification is also there, which can be seen in calcified lymph nodes also, and it can be seen in the malignancies also. So that will also be given higher points. So these are the 5 things which we typically look for when we are doing a TIRADS risk stratification, because this is the point from where picking up the patient will start. If you have done a correct risk stratification, then the patient will go in one direction. And if you have you have said that the lesion is benign, it's not a cancer, then the patient will go in another direction as far as the clinical management is concerned. So this is very important to see each of these features very systematically. Then certain things which are not included in TIRADS, like I mentioned about the color Doppler and elastography. So here also you see that the flow, if the lesion is having lot of flow, as you can see color flow is there inside the lesion, it is more indicative of a malignancy as opposed to a benign lesion, which is unlikely to have much of flow inside the lesion. So these are the 2 variants as far as Doppler is concerned. You can take the velocities also, you can take the waveform also, and then according to that also you can decide that what are the chances of it being a high grade malignancy or a low grade malignancy. So this is one feature which we can add to our diagnosis, but then this is not included in the TIRADS scoring. And the second important one is the elastography, which I mentioned. So these are not included by the American College of Radiology in the TIRADS, but then in clinical practice we use these also to support our diagnosis. And so that is what I was mentioning, that once you give points to each and every feature, you add up of those points, and after you add up those points, you put it in these blocks. So a lesion which is having 0 or 1 point, in that there is less than 1% risk of it being a malignant lesion, and a lesion which is having more than 7 points, more than 20% malignancy risk. So that is what I meant by risk stratification, that when you evaluate a patient, you can counsel the patient as to what are the odds of the lesion which he or she is having in the thyroid of being a malignant lesion in long term. And in the intermediate, you see that the ones which are having lesser points are less likely to be malignant. And so it has been divided into benign, not suspicious, mildly suspicious, moderate, and highly suspicious. So in short, it's a very simple system of risk stratification, and the main use is to pick up the patient at the right stage, number one, and number two, to counsel the patient. And not only this, once you are able to correctly stratify the patient into one of the categories, you can decide that what should be done further. So if it's a one which is having a TI-RADS 5 score, that is 7 or more, then the patient and the lesion is larger in size, patient should go for a biopsy or FNAC. If it is TI-RADS 4, but it is more than 1.5, so you see that as the TI-RADS category is increasing from 0 to 5, the size of the lesion, the threshold of size at which a biopsy is advisable, is reducing. And if it's a very small lesion, it's TI-RADS 1 or 2, then you can just observe the patient. So this small exercise gives lots of confidence to the patient as well as to the person who has referred it to you. And there is a surveillance protocol also that can be followed after you do a correct risk stratification, because many times you will find patients coming to you and asking कि अब अगर if there is a nodule, you tell them कि ये cancer नहीं लग रहा है, but the next question patient will ask कि अगर cancer नहीं है तो गांठ तो है, हमें क्या करना चाहिए, इसको कितने दिन में अल्ट्रासाउंड कराना चाहिए. Thank you. So the TI-RADS system not only risk stratifies but also gives a guidance as to what should be the future course of action after detection. And it's a pretty simple thing, and all of us should learn, I think, how to do it and how to interpret it and how to explain to the patient. Those who are not radiologists, the point which I want to put across to the non-radiologists is that how should you put across it to the patient that if this is the risk score, then what should be the outcome. Many, apart from ACR TI-RADS, many different organizations came up with their own scoring system or their own risk stratification system. But unlike the ACR TI-RADS, the Thyroid Association, the European Thyroid Association, the Korean Association, they came up with systems which are predominantly based on the imaging pattern and not on the risk scoring. So till now, it is the ACR TI-RADS which is considered as to be the most useful and most objective. It is the most objective system, but now they are trying to come up with a system which incorporates the best feature of each of these. And now there are equipments which are coming which integrate the role of artificial intelligence in doing this TI-RADS scoring. So I think in short, this is a very useful technique, and this is where the risk stratification, picking up the patient and counseling of the patient starts. And then later on, obviously, the role of nuclear imaging, the role of MRI. Now there are small coils which are coming, neck coils, in which you can do MRI and characterize the lesion further, and the role of biopsy and FNAC comes. So that was all about ACR TI-RADS and risk stratification. And thank you again for inviting me over here for this talk. Thank you.
Thank you, sir. Now I would like to call Dr. Ankita ma'am to please felicitate Dr. Ashish Verma, sir. I would like to invite Our next speaker, Professor Dr. N.K. Agrawal, Associate Dean Research and Projects, Department of Endocrinology, IMS BHU, to share his insights on the topic Dynamic Risk Stratification in DTC after the first ablation.
Good afternoon, everybody, and I am thankful to Dr. Ankita, Dr. S.K. Singh sir, and Dr. Patel and others to invite for this CME on the inauguration of the high dose iodine, radioiodine and lutetium therapy. It is a very important addition to the armamentarium of care for the patients for the thyroid cancer and other endocrine and these tumors also, and the prostate cancers also. So after we know that the thyroid gland has two types of cells, follicular cells and parafollicular cells. So there could be the tumors arising from the follicular cells and the parafollicular cells. So follicular cells give rise to differentiated and undifferentiated thyroid cancers, while parafollicular cells give rise to MTC. As the number of patients of papillary thyroid cancers are the most, comprising of the differentiated thyroid cancers, and very few number of cases are follicular thyroid cancers. Other thyroid cancers are less. So we first try to stratify the risk of developing cancer, and we follow up these patients. This is all after the therapy has been done for surgery, or sometimes we find the risk stratification before surgery, and later on when after surgery and radioiodine therapy the stratification changes. So we have to follow up and see the response to treatment. So post-operative we try to suppress the growth of the remaining tissue. So if we have thyroid lobectomy or isthmectomy, then we measure the TSH after 6 weeks of surgery, and we target the TSH at 0.5 to 3 after with thyroxine therapy. And if there is a total thyroidectomy, the radioiodine scanning and ablation, if it is unlikely, then we start levothyroxine immediately post-op. And if there is a possibility that radioiodine scanning and ablation is likely, we will like to raise the TSH by not initiating the thyroxine or initiating T3, and we wait for the rise of TSH, or may use a synthetic TSH to increase the uptake of the radioiodine. Then we see the recurrence risk in patients of thyroid. So non-invasive follicular thyroid neoplasms, they are the papillary-like nuclear features, and they are not very heavy in recurrence. So these are not, these are just followed up. Then papillary thyroid cancers may have a low level of recurrence when there is no macroscopic tumor tissue remnants after resection. There is no locoregional invasion, clinically non-zero or pathological N1 disease, that is less than 5 micrometastasis, and each measuring less than 0.2 centimeters. There is no distant metastasis. There is no radioactive iodine avid metastatic foci. There is no vascular invasion, non-aggressive histology, and BRAF V600E mutated PTC can be assigned to the low risk category only if the tumor is less than 1 centimeter. So there are features which suggest that there is a low level of recurrence. So if these are present, and in case of follicular thyroid cancers, if the tumor was intrathyroidal, well differentiated, with capsular invasion and minimal or less than 4 foci or no vascular invasion, then there is a low risk of recurrence. Then there is an intermediate risk. The features are again microscopic invasion of PTC, tumor-related symptoms, intrathyroidal tumor measuring less than 4 centimeter, BRAF mutated, aggressive histology, vascular invasion. So many features are there. With FTC, at least one of the following, that is clinically N1 or pathological N1 disease, that is more than 5 involved lymph nodes, each measuring less than 3 centimeter. So there was a lymph node involvement, then we can think of that there is an intermediate level of risk. And then we do a radioactive iodine scan, and there is radioactive iodine avid metastatic foci in the neck on the first post-treatment whole body scan. So there we can see that there will be intermediate level of recurrence. Then high risk in PTC and FTC, these are the features where in PTC there is gross extrathyroidal extension, N1 disease measuring more than 3 centimeter, extranodal extension, concomitant BRAF and TERT mutations, post-op thyroglobulin suggestive of distant metastasis, incomplete tumor resection, or we can see that there is a distant metastasis. Or in FTC, there is at least one of the following, like widely invasive or extensive vascular invasion, post-op thyroglobulin suggestive of distant metastasis, incomplete tumor resection, again distant metastasis preoperatively, there is a high level of recurrence risk. So, what to do about the and how to follow up? Like risk of recurrence between the 3 categories. Non-stimulated thyroglobulin has to be done every 4 to 6 weeks and 3 to 6 months and 9 to 12 months in all the categories. Neck ultrasound has to be repeated at 6 to 12 months in low and intermediate risk, but every 6 to 12 months in high risk categories. Whole body scan is usually not indicated in low risk, may be indicated in intermediate, but can be done in high risk. MRI CT will not be indicated unless thyroglobulin is elevated or high clinical suspicion is there in high recurrence risk. FDG PET is only indicated in high risk cases when thyroglobulin is more than 10 nanogram per ml. And the goal of TSH, again, when we try to suppress the growth of the tumor through thyroxine, it is 0.1 to 0.5 if non-stimulated thyroglobulin is detectable, and if between 0.5 to 2 if non-stimulated thyroglobulin is undetectable. So there is no residual tissue, then you do not need to suppress the TSH to a very low level. And in intermediate risk, it has to be suppressed to the level of 0.1 to 0.5, and in high risk category, you suppress the TSH to less than 0.1. So from earlier, we have moved on to less suppression of TSH and allowing more TSH to be there. Coming to the radioiodine therapy, where pre-treatment scan can be determined for the extent of residual disease, and low dose 2 to 5 millicurie and scan obtained after 48 to 72 hours of administration. And again, the ATA risk scoring, I will not go for more into that because other experts are available. So radioiodine features and requirements are there which can stratify, and they will change according to the risk of recurrence. So dosing again is when we can do a remnant ablation by 30 millicurie, and adjuvant treatment of subclinical micrometastatic disease by 75 to 150 millicurie, and metastatic disease we can do a 100 to 200 millicurie. So this high dose therapy may be required here. So we can see the response to whole of this treatment of surgery and radioiodine, and when there is a negative imaging, there is undetectable thyroglobulin antibody, and thyroglobulin is well below 0.2 nanogram per ml, and stimulated thyroglobulin is less than 1 nanogram per ml, we say that is an excellent response. Biochemical incomplete response, where the imaging is low, negative, but thyroglobulin is still present. Structurally incomplete, where imaging evidence of disease is there, and it is regardless of presence of thyroglobulin, because it will always be there. And intermediate, when there is non-specific imaging findings or faint uptake in thyroid bed on radioactive iodine scanning, or thyroglobulin is 0.2 to 1 nanogram per ml, or stimulated thyroglobulin is 1 to 10 nanogram per ml, or thyroglobulin antibody is stable or declining in patients with no imaging evidence of disease. So there will be an intermediate risk response, and so then we can go for the thyroidectomy alone, or where the patients have been given radioactive iodine, and then these are the cases where only thyroidectomy alone has been done. So excellent response is negative imaging, undetectable thyroglobulin antibody, and thyroglobulin less than 0.2. Biochemical incomplete is negative imaging, and thyroglobulin is still elevated more than 5 nanogram per ml, or rising thyroglobulin values with similar TSH, or rising thyroglobulin antibody levels. Structurally incomplete, like imaging evidence of the disease, and indeterminate, or when there is non-specific imaging findings, or thyroglobulin is 0.2 to 5 nanogram per ml, or thyroglobulin antibody levels are stable or declining. So there are various responses to treatment also. And then when lobectomy alone has been done, so there could be excellent, biochemically incomplete, structurally incomplete, and indeterminate responses. Again, the excellent response is when there is negative imaging and undetectable thyroglobulin antibody and stable thyroglobulin levels. Here you will find a thyroglobulin level because one of the lobe is still there. Biochemically incomplete response when the imaging is not affected, but rising thyroglobulin values, and structurally incomplete when there is a residual disease, and indeterminate when non-specific imaging findings are there. So what is the management based on the stratification? So we can go for non-stimulated thyroglobulin when there is excellent response to therapy every 1 to 2 years, biochemically incomplete every 6 months, structurally incomplete every 6 months, and indeterminate 6 to 12 months. Stimulated thyroglobulin is not needed in excellent response, but may be repeated in biochemical incomplete or indeterminate. Neck ultrasound can be considered every 3 to 5 year interval in excellent response, but may be earlier done with the biochemically incomplete, structurally incomplete, or indeterminate responses. Other modalities are also indicated. FDG PET is only in structurally incomplete response, where to identify additional sites of disease and for prognostic purposes. The TSH again remains between 0.5 to 2 in excellent, 1 to 0.5 in biochemical incomplete, and indeterminate 0.1 to 0.5 milliunit per liter, while in structurally incomplete we try to suppress further because we have found the tumor to be there. So in nutshell, when we do the therapy of thyroid cancer, we apply different modalities, surgery, radioactive iodine, and other. So then we will try to assess the response and possibility of recurrence of the disease, and if there are various parameters to assess its recurrence, and when the parameters are like that, we can classify the response into excellent, biochemically incomplete, structurally incomplete, or indeterminate, and further treatment can be decided. Thank you for patient listening.
Thank you, sir. I would now request Dr. P.K. Pradhan, sir, to kindly felicitate Dr. N.K. Agrawal, sir.
You used to be an Ontario only, never met.
We were nodal officers of the telemedicine in U2 and SGPGIMS.
I would now like to invite our next speaker, Professor Dr. Asim Mishra, Head of the Department, Head and Neck Surgical Oncology, MP MMC and HBCH, to talk on the topic Surgery for Successful Radio-Iodine Completeness, Nodal Clearance Discussion, Decision Making and Common Pitfall. He will be joining us online. Sir, are you online?
Yes, sir, it's visible and you are audible as well.
ऑन तो है, माइक्रो पे तो है। फुल है, फुल है।
And this we say because we have a data with us, we operated patient. Percent of our surgeries that we do are radio surgeries. There are nodes present. So all those things we are going to do, optimize the treatment and follow the surgery management. And why a complete surgery is important? Because we leave behind even a small amount of thyroid tissue, the nuclear medicine specialist is going to have a significant amount of uptake, and then the patient has to redo surgery because that scan will also become ineffective. So it is important in a complete, the completeness of the surgery is important, and how it has to be done, I will come to that. Radioactive iodine will not compensate for an incomplete surgery. Radioactive iodine has a limited dose probability. It cannot be given more than 600 to 800 millicuries. Beyond that, the patient is going to have bone marrow suppression. So it is important that the surgery is done completely. There should not be any notes. Why it should not, that's also I am going to discuss. All thyroid cancers are not very aggressive, as Dr. N.K. Agrawal also pointed out, and he has very correctly risk stratified all the lesions, and that is very important that once we have operated, we follow the correct risk stratification. Once again, if we are finding that the disease is large or the thyroid nodule is very big, that doesn't mean that we also have to do a central compartment or lateral compartment neck in that. So patient selection and management is very important. And all or majority of our thyroid nodules are incidentally detected. The patient is visiting the doctor for some swelling or change in voice or hoarseness, and a sonography is done, and then a nodule is detected on a USG. So just because there is a nodule in a sonography does not mean that it is going to be malignant. And even if it is Bethesda 3 or Bethesda 4 or an FNAC, does not mean that we have to operate upon that nodule. So that also is an important aspect that we have to look, and I will just cover in the next 5 to 7 minutes. So almost 100 incidental detected nodules that we find on a sonography, only 8 to 20 or 40% are malignant, not all of them. If the patient had a previous malignancy, there is a higher chance of it being malignant. Otherwise, in a CT scan or a PET scan or a sonography, if there is an incidentally detected nodule, the first thing that we must not do to a patient is to make him or her anxious for having a cancer. This is the reason, because this is a landmark publication in 2016 in NEJM, where it was shown that thyroid is coming as a cancer epidemic. Not only in India, it's in all the developed part of the world, in the United States, in France, in England, in Japan, in Australia. And there is a sudden surge of detection of thyroid malignancies because of the increase in the diagnostic modalities, increase in the screening programs, and this is going to increase in our country as well. So therefore, and almost in the last slide I showed that almost 50% of the surgeries were unnecessary. So we have to bring down those 50% of the unnecessary surgeries so that the patient that actually deserves surgeries can be operated. Dr. Ashish has rightly classified the ACI thyroids. All reporting of the sonography must be done in that manner in the preoperative phase. They should be classified properly according to the thyroids classification, and if the radiological report does not have the thyroids, it must be reviewed with the radiologist. Unless we have that in that manner, we will never be able to report our thyroid nodules properly. Similarly, once we have the thyroids, and if it is indicated to do an FNAC on thyroids, only then a FNAC must be done to confirm what is the Bethesda category of that nodule on cytology. Because based on the Bethesda classification, there will be risk of malignancy, and the treatment planning will change according to that. And not all microcarcinomas. So even if it is a Bethesda 5 or Bethesda 6 on FNAC, less than 1 centimeter nodule isolated in a female of 25-23 years who have not completed family, or even incidentally detected who is undergoing surgery or treatment for some other malignancy in the body, all of them do not need to be operated. A lot of them can be observed. A serial ultrasound at 6 or 12 months can be done, and those surgeries can be prevented. Now there is a word of caution, because there is cancer. We know there is Bethesda category 6 report. So there are some cancers where we do not have to observe, we have to operate upon them no matter what. These are when the nodule is in a 15-year or less than 15 years age patient. There is a history of childhood radiation exposure. There is a family history of thyroid cancer, and if it's a multifocal or an aggressive feature on cytology. These nodules we must never and never observe. We have to operate upon them. Now, what surgery? If the thyroid nodule is less than 1 centimeter, there is no doubt. Single lobe, you only have to do a hemithyroidectomy. These are low risk. We do not have to do even a total thyroidectomy. The survival is good. Even if there is recurrence or nodule that subsequently appears on the contralateral node, that can be salvaged. And this is almost 18 years, now 15 years plus data present with us. Even the ITO group from the Japan is showing up to 30 years of survival in these patients. So we do not have to operate upon these tumors. These can be safely managed with lobectomy alone. Now, if we are doing a total thyroidectomy, so most of the malignancies and most of us are very careful about treating malignancies. So we know it's a papillary carcinoma thyroid, it's a 2 or 3 centimeter. We know what surgery has to be done. We have to do a total thyroidectomy. But when we are doing a total thyroidectomy, we have to ensure certain places where very commonly this thyroid tissue is left. And any nuclear medicine specialist who is practicing can very well relate to this, because very often we'll find that there is a remnant thyroid tissue in the thyroid bed, and they have to overdose or treat those patients with a higher dose of radioiodine, or even send the patient back for surgery again. So whenever a remnant thyroid tissue is for more than 15% uptake on RAI, that means the surgery has not been done completely. So the completeness of the surgery is very important, and the regions where it is commonly left is near the Berry's ligament, where in order to preserve the recurrent laryngeal nerve, many a times the thyroid tissue is left, or in the residual pyramidal lobe, because pyramidal lobe is in the center part, and many people would not go in or dissect in that area or leave the tissue in the thyrothymic tract. So these are the areas of the tubercle of Zuckertandl. So these areas must be carefully dissected out, especially when we are treating a thyroid cancer, because leaving thyroid cancer will not be able, patient will not be able to complete a good RAI therapy. Now, what are the common pitfalls when we are managing for radioactive iodine? So if we have not identified a central compartment node, now these are very common problems that nuclear medicine and the surgeon are going to interact once they are commonly operating and dealing with each other. If you have a central compartment node, after surgery you are seeing a 1 centimeter node in the central compartment. These nodes do not take up radioiodine. Or if there is a lateral neck node present, or a metastatic node along the recurrent RLN or trachea, these nodes are not going to take up radioactive iodine. The reason is sodium iodine symporter. The thyroid has very high density of sodium iodine symporter, and that is why the radioactive iodine uptake is there. In the nodes, the density of sodium iodine symporter is very less. That node is not going to be radioactive iodine avid. And as the number of nodes or the size of the nodes is larger, the NIS expression is going to further go down. So, when we are doing like dissection, it is important that it is done properly. And whenever there is a central compartment node, it has to be dissected out properly. And in these are the patients of T3, T4 tumors, or in patients where there is a lateral node that is positive. So in all those patients, a good central compartment neck dissection must be done, and this is as per the ATA guidelines of 2025 as well. Now, lateral compartment neck dissection, when it is to be done, whenever we have a positive lateral neck node, a lateral neck dissection must be done in a thyroid cancer. We cannot avoid it. Now, we will always say which patients to identify and how to identify that they are going to have the node. One is on a good radiological assessment. The radiologist will tell us there is a central compartment node and the lateral node. Other than that, there are certain patient-related and tumor-related factors, like T3 or T4 large tumors, patients who are less than 15 years of age. Papillary carcinoma is the highest incidence, and that is the most common differentiated thyroid cancers. These are the highest harbinger of central compartment neck nodes. And in patients with positive BRAF mutations. So ensure that your pathologist is always reporting his histopathology report, the BRAF and the TERT mutations, because this is going to help us decide the further treatment as well. Now, certain other predictors of compartmental metastasis is male patients. Whenever there is a male patient, ensure that you do a good central compartment inspection to ensure that there are no central compartment nodes present. Whenever the size of the thyroid nodule is more than 1 centimeter, the chances of having a central compartment nodule metastasis increases. Patients who have extensive extrathyroidal extension or LVI or microcalcification on USG. These features will keep on shifting from one. So these are 3 different studies that have shown. But these are the features that we have to be careful whenever we are dealing with such a patient. We have to ensure that the inspection is done intraoperatively so that we do not have to do a redo surgery. So now, based on these, my take-home message for everybody, especially the surgeons, would be, so whenever you are doing a surgery for a thyroid malignancy, ensure that you do a complete thyroidectomy if you are doing a total thyroidectomy. The thyroidectomy has to be done along with central compartment node whenever there is high-risk features of having central node, or on sonography there is a presence of central compartment node, so that when the patient is sent for RAI, RAI can be done properly. Leaving thyroid tissue, leaving central compartment node, this is going to affect our RAI therapy, and we must always avoid that. We must recognize pre-operatively by discussing with the radiologist what is the actual nodal burden and high-risk features of thyroid nodes, so that we can operate properly and give a good outcome to our patients. Thank you so much.
Thank you, sir, for your valuable insights on this topic. Any question? Sir.
Myself Prashant Pradhan from SGPGIMS.
Yes, sir. Good evening, sir.
I just want to tell you very clear, when there is
You can give lesser dose of radioiodine because
So your voice is lost.
thyroid remnant uptake is 1%. So your surgery may not be so, you don't require to do a aggressive surgery. That's why earlier days
We are not able to hear you, sir.
total thyroidectomy. But now the difference between metastasis and remnant has to be there. So even if you leave because of some reason, I think you can easily treat it, and that's why I always say radioiodine works like surgery without.
It is, sir, your mic, this is muted, voice is muted.
Ajay, this is muted. Are you listening to me?
sorry. Hope now you are listening.
Yes, sir, please.
Okay. What I wish to convey you is that remnant tissue ablation is very easy.
But metastatic tissue definitely.
Yes, sir. So remnant tissue ablation is very easy, but whenever remnant tissue ablation is present with a chances of metastasis or whenever
want to convey you.
because we are doing, yes, sir. Because this is something we also have been discussing, and as you work in SGPGI, sir, so we have this problem whenever there is higher load of metastasis and the patient has to undergo multiple cycles or sittings of RAI. So initial, if there is only low risk thyroid malignancy, we don't have to do RAI right now. So we don't have to go for any ablation. So leaving thyroid tissue is not at all necessary. Just because a remnant thyroid tissue is left, and that is why RAI has to be done, that would not be a very ideal practice.
But the point is, it is not just radioiodine ablation. It is basically you have to measure also stimulated thyroglobulin and antithyroglobulin antibody.
Yes.
And then if there is no tissue, but your disease is rising, then you will be cut off. Then radioiodine is a requirement now.
Yes, sir.
So indication of radioiodine, as you rightly pointed out, is very correct that the rising trend of thyroglobulin must be there. I am talking about the surgical completeness. My topic was surgical completeness.
Yes, agree.
It is very important that
Thank you very much.
done properly. Thank you so much, Dr.
Thank you, Dr. Singh. Any other questions? Thank you so much, sir. Now I would like to invite Dr. P.K. Pradhan, sir, Professor and HOD, Nuclear Medicine, SGPGIMS, to talk on the topic Iodine-131 therapy in 2026, patient selection, dosing approach, and post-therapy scan interpretation. Thank you.
Yes. Is it okay? Good afternoon to everybody. I think thanks Apex Hospital and Dr. Suraj for inviting me and their organizing team. I think it's a very lovely moment that the treatment has come to your doorstep. And my job has become very easy because many of the speakers have already explained regarding radioiodine therapy. But still, nevertheless, I think in a very simple term, किसी को मेरे को लगता है कि सारे मोस्टली पैरामेडिकल स्टाफ्स बैठे हैं जो कि रिक्वायरमेंट है पैरामेडिकल स्टाफ्स की जब टेक केयर करते हैं पेशेंट्स को रेडियोआयोडीन ट्रीटमेंट के दौरान. I think there are also some precautions to be taken during radioiodine therapy for the patients. So I think I will make it very simpler to understand and little bit of history also. And I think Suraj, only thing what I will tell you, if your time is over, please tell me that you can stop. I can stop any time. Otherwise I will go on speaking to explain you. Okay, you know I am a true teacher. Whatever you ask, I can explain you really regarding the radioiodine therapy. Because we are doing since more than 30 years, I am since 90, I am doing this therapy. So you can imagine that coming to the radioiodine, if you look to the historical background, radioiodine has been utilized since 1938 in the Massachusetts hospital that is Harvard Medical School initially, and everybody knows now the thyroid has a natural predilection for concentrating radioiodine because the inorganic iodine is required for our hormone synthesis. That's why a radioisotopic iodine is also very important for treatment, and it is utilized for more than approximately more than 85 years for thyroid cancers, and initially for benign thyroid diseases and later on for thyroid cancers. This is the first publications which has been utilized for Graves' disease, the thyrotoxicosis. If you look to the iodine-131 as a radionuclide, you see there are many opportunities for iodine-131. For benign disorders to treat, 85% of the patients of thyrotoxicosis are Graves' disease. They can be easily treated with radioiodine, but nevertheless, I have just enumerated what are the benign diseases. But now the point has come to treatment for the cancer actually, the thyroid cancers. These are malignant diseases. I think already you have listened to the few speakers. This is mostly 85% are papillary thyroid cancer, follicular thyroid cancers and Hürthle cell cancers, which has now been defined in 2026 as OTC. This is basically oncocytic thyroid cancer. So they have been kept as a different group, and they are thought to be little resistant to radioiodine. That's why they have been separated now to this, but they are very minority. The majority are papillary and follicular thyroid cancers, and we have also importance because the sub-Himalayan belt of Ganges, we have more follicular thyroid cancer in comparison to the western country. Because they are a hematogenous spread, blood spread, So it simply spreads to the whole body, to the lungs and bones. That's what is the behavior of follicular thyroid cancer. And if you look to the malignant thyroid diseases, I think there is no doubt that all metastatic thyroid cancers, whether it is papillary or follicular, they should be treated with radioiodine. I think I have shown you the publications, they are very seminal publications. There is no doubt about, there is no debate about this. But however, people debate regarding the remnant ablations. If suppose the surgery has been done and the surgeon has left a little tissue which will be seeing, but in my hospital some to 5 to 7% patients don't show any tissue, so we don't give radioiodine unless after the scanning. But majority of the patients requires radioiodine therapy for thyroid cancers. And the basis of thyroid cancers, molecular basis, is sodium iodide symporter, which we never knew in 1938. We knew this molecular basis only in 1996, which has been by Nancy Carrasco group from United States of America. That there is an active transport mechanism of iodine from the blood, vascular blood pool to the follicular cell of the thyroid. That's how the natural target, and that's how the radioiodine goes there. If you look to post-thyroidectomy, most of the patients to nuclear medicine will come referral from the following the thyroid surgery because of the malignant thyroid nodule which has been proven by ultrasound, then FNAC, then surgery done, then they will land up in the nuclear medicine department. And you will see different variety of, you can see there will be no tissue in iodine 1 scan. There will be, if you utilize another isotope called technetium, you can see the whole lobe. You can see also the multiple uptake you can see in the third scan with the technetium pertended scan. So the surgeons will definitely vary. Nevertheless, the radioiodine I told you, if you give radioiodine, this can work as just a surgery without knife. The reason being that goes and that causes a single stranded break, and the cell will not repair, and that will have a cell killing effect, and you will not see further with radioiodine. That's the beauty of radioiodine. This is just to scan to show you how following surgery there are tissues in the neck and the lymph node in 1992. I think and subsequently you can see 3 lymph nodes were there, and in 94 after giving repeated doses of radioiodine, this has been cleared from completely the neck. That means it can remove the remnant thyroid tissue as well as the lymph node. Coming to this is a papillary cancer thyroid patients with lymph node metastasis. So you can see in the whole body, this is done with a gamma camera image. This is a whole body planar gamma camera scan. But I think somebody has given me that in 2026 what they are suggesting. They are suggesting all these imaging has to be done in a gamma camera, but with the newer technology called SPECT-CT, where you will have 30% incremental value, so that you can see better the lymph node, you can see the surrounding structure, you can distinguish between which patients will go for further surgery or radioiodine therapy. That's what is in 2026. This is just to demonstrate to you how the lymph node and the remnant metastasis in the neck following surgery. Long mets are there. Do you have a pointer? I think you are seeing these are lungs posterior image. This is the remnant, and this is a mediastinal lymph node. Okay, and this has been cleared after repeated doses of radioiodine. The lung is clear now. Okay, that means radioiodine cures the disease. That is the value of radioiodine. This scan I am showing, this is a follicular cancer thyroid. You can see there is a pelvis there is a huge metastasis and also the lungs. This this is a combinatorial approach. It is not only radioiodine, sometimes following radioiodine, you need also for the soft tissue component where radioiodine doesn't go, you can combine the radiotherapy. That's what I want to demonstrate with this. And that's what in 2026 the ATA guideline says, you must combine this treatment following the doing SPECT-CT. That's the emphasis now. You can see this is the concentration, but the center you can see that there is no uptake. These are all soft tissue. They require radiotherapy also after 3 months to 6 months of iodine therapy. That's what is the way of the treatment. I'll show you what is the value of SPECT CT scan. Sometimes if you see this planar scan, you will think that this is a remnant tissue following surgery in the neck. That means it is a normal thyroid tissue. But if you do a SPECT CT, you see this is in the cervical vertebra, it is not in the remnant. That means it is not a thyroid. Had it been thyroid tissue, I could have given 30 millicurie. But now it is a bone tissue, bone spread, that means I have to give 200 millicurie to this patient. That's what the role of imaging in 2026, that you can change your treatment according to the best image, which is around 30% incremental value with the gamma camera SPECT CT. That's what I have. This is also another scan. Sometimes in one patient we utilize multiple imaging modality. This is a iodine scan in a 63-year-old lady. This is the MEB scan. Sometimes that lady says, she is a wealthy lady. She lives in Delhi as well as Lucknow. She says me, sir, I cannot have recurrence. After 7 years, she had recurrence. Okay. When I palpate the neck, I realize something wrong is there. Then I told, why don't you go for an ultrasound? बोला नहीं सर, आपके पास कुछ है तो अभी करा दीजिए, और कहीं जाने वाला मैं नहीं हूँ, 7 साल हुआ तो आपके पास आ रहा हूँ. तो मैं बोला अच्छा ठीक है, कोई बात नहीं, अभी एक मीबी स्कैन करते हैं. वी हैव अनदर आइसोटोप with technetium labeled, and we demonstrated that there are recurrence in the neck, and sometimes she has also wedge collapse in the back. उसको back pain होता था, and that back pain is not related to this disease. This is a benign back pain. Okay, malignancy cancer के लिए नहीं है. So this is what we do in the nuclear medicine by utilizing multiple imaging modality. I will not go into detail because this will take a long time. I think radioiodine therapy is a requirement for metastatic disease, for ablation, for the remnant thyroid following surgery, for metastasis and also recurrence. But I will emphasize the most important part is the follow-up, either in-person follow-up or tele follow-up, whatever you do. But in spite of all these efforts for last so many years, I think almost 90 years we are reaching, I think still there is a significant patients of populations following their treatment goes to not concentrating radioiodine. This is in the range of almost 15% to 30%. So what do we do also, I will show you. Then subsequently I am not going to, they basically remove the primary remnant thyroid tissue as well as the tumor with radioiodine. They minimize the risk of recurrence, and that's why that you must have had the stratification low, intermediate and high risk. Now in 2026 they have changed it to low intermediate and high intermediate risk. That is the kind of this. Risk means what is the percentage of recurrence. कितना रिकरेंस होगा हम ट्रीटमेंट करने के बाद, वो मरीज पूछेगा तो आप बता सकते हैं. पोस्ट ऑपरेटिव ट्रीटमेंट विथ रेडियोआयोडीन व्हेन अप्रोप्रिएट, एंड एक्यूरेट डायनामिक स्टेजिंग करना है. ईच टाइम व्हेन द पेशेंट कम्स टू योर क्लिनिक you can upgrade, you can downgrade, and you can say that you are free of disease or you have recurrence. And accurate long term surveillance जरूरत है. Minimize disease related morbidity, but how often to call these patients? If it is a low risk, you can call them yearly. If it is a intermediate risk, you can call them 6 months to 9 months. If it is a high risk, you must call them 3 monthly. Okay? So depending upon the risk, this is called a risk adapted approach. That's what I want to tell. I am not going into the rationale of radioiodine therapy, I think ablating and destroying, but 3 things are very important for thyroid cancer. I think one is surgery, following surgery radioiodine therapy, and the thyroxine suppression. ये छोटा सा टिकिया है ना, बहुत important है. वो जो thyroxine suppressive dose is extremely important, otherwise patient will have recurrence, and it is cheap. So the all 3 have equal role to play in thyroid cancer treatment. That's what I want to emphasize. And you see, age जैसे बढ़ता है, when you increase the age, definitely radioiodine works, but the survival, overall survival decreases. over the age. That's what is the risk factor for thyroid cancer. And TSH, recombinant TSH can be utilized. Any patients which cannot be hypothyroid, it is little costly, but definitely your synthetic thyroid is there, which you can TSH you can utilize for increasing, because when you increase the endogenous TSH, then only the iodine uptake will be there to the metastatic tissue. I think the preparation of the patient is very important. You need to ask, are you taking some cough mixture? Do you have contrast injections? So iodine containing drugs should be avoided. That's what is the kind of preparation, and we utilize, and once we give orally iodine, then 5 millicurie, then after 48 hours the imaging is done, and post therapy scan done at the time of discharge of the patients when you give therapy. After that, when the patient is discharged, on that day itself there is another scan done, because it has been realized that if you give more dose, you can see the more lesion, that's why it is done. Okay? These are post treatment precautions you have to take, like where to keep the linen, how do you, because you have to be separated from the family little bit in another room, isolation for almost a week, 5 to 7 days. So there is a cardinal principle of 3 meter. If you allow 3 feet, that means approximately 1 meter. That's good enough. Okay? With the precautions what you can do, that's what it is there. You have to take your food separately little for 5 days, and you can go to the toilet or urinal and flush it, because 80% of the iodine goes by 48 hours through urine only, and little with excreta. These are the precautions which you have to take when you give radioiodine. These are the risk stratifications. I will not go into the detail. I have told only one thing, that depending upon the risk, your follow-up strategy will differ. Your thyroxine suppression will also differ depending upon the risk. Okay? Lesser dose for the low risk and a higher dose for the high risk. So this is what. And less time for follow-up with the high risk and more time for follow-up with the low risk. That's what I want to pass the message. So if you look to the development in the past 2 decades, I think one is a synthetic recombinant human TSH has come, which can be without of making stoppage of thyroxine, you can treat with radioiodine. Lobar ablation, कोई सर्जन बहुत अच्छा नहीं है, कोई बात नहीं है, फिर भी हम निकाल लेंगे रेडियोआयोडीन देके, ये बहुत इंपॉर्टेंट चीज़ है. ये अभी मेरे को डॉक्टर प्रोफेसर अग्रवाल पूछ रहे थे कि डॉक्टर साहब करते हैं क्या इसको, मैं बोला हाँ हाँ सब करते हैं. Everything is possible, only you have to think what is not possible. And so expanding role of iodine 131 in various tumors, हम लोग कुछ रिसर्च भी कर डाले कि ब्रेस्ट कैंसर में क्या रेडियोआयोडीन जा सकता है, उसको हम अभी रिसर्च में है. एंड फॉलोअप इज ए वेरी इंपॉर्टेंट कंपोनेंट ऑफ थायराइड कैंसर मैनेजमेंट. मैं पेशेंट्स को बोलता हूँ, दूसरा सब लिटरेचर, अमेरिकन लिटरेचर लिखता है, यूरोपियन लिटरेचर लिखता है, 2 साल हो गया, 3 साल हो गया तो छोड़ दीजिए. The very strictly I say to the patients every time, आप आजकल बर्थडे बड़ा जोर मनाते हैं, तो हर बर्थडे में हमारे पास एक बार क्यों बर्थडे नहीं मनाते हैं, साथ में मनाएंगे. आप अस्पताल को एक बार जरूर टेम्पल जैसा विजिट करिए, उसमें आपकी फॉलोअप भी हो जाएगा, आपकी बर्थडे की याद भी हो जाएगा, और आप चाहे तो इकट्ठा मिलके बर्थडे मनाएंगे. ठीक है, उससे अच्छा है और क्या हो सकता है. आप अच्छे होंगे, दैट विल गिव ए बिग एश्योरेंस टू यू दैट यू आर फ्री फ्रॉम द डिजीज. ठीक है, सो दिस इज द व्हाट डेवलपमेंट. एंड पेट स्कैन करते हैं जब आयोडीन नहीं जाता है और सीरम थायरोग्लोबुलिन जब इंक्रीज हो जाता है और एंटी थायरोग्लोबुलिन इंक्रीज हो जाता है, उसी टाइम पेट स्कैन किया जाता है. बिकॉज पेट स्कैन करने से, पेट स्कैन गामा कैमरा स्कैन से बेहतर है, बिकॉज उसका मैकेनिज्म अलग है. Every cancer cells utilize more glucose rather than the normal cells of the body. That is the basis of PET scan. And you can see that whole body radioiodine scan negative hai. And when we did the PET scan, you can see the lymph nodes in the neck and the lung. Okay, this is what you have to demonstrate. But
even if the TG and ATG is increased and the PET scan becomes normal, then you can easily explain. Somebody was telling कि central compartment detections nuclear medicine कर नहीं पाता है, वो surgeon सोच रहे थे. आप देखिए central lymph node compartment, both lymph nodes are seen. Okay, so I think you need to understand what we are demonstrating. It is not that, and these patients went for again surgery, and we could able to remove after doing FDG PET scan. These patients, 1/3 of the patients can go to surgery following FDG PET scan. That's the importance of PET scan. And if PET is shows clear, let's say PET scan बोलता है कि कुछ भी नहीं है, कोई तकलीफ, TG बढ़ा हुआ भी है, ATG बढ़ा हुआ है, मैं मरीज को समझा देता हूँ कि कोई दिक्कत की बात नहीं है, आराम से आइए, देखते हैं आगे आगे चल के क्या होगा, ठीक है? Because that means indirectly saying cancer cells are not utilizing glucose. That is good, very good. So we don't have to worry. That's what I explained. I think Suraj must be thinking, Dr. Suraj gave me a topic in 2026. Actually वो 2024 होना चाहिए सूरज, क्योंकि 2024 तक डाटा ही अमेरिका वर्ल्ड में अभी लिया है. दूसरा मैं सोचा सूरज को कुछ गिफ्ट देना चाहता हूँ PGI से. ये आफ्टर द रेडियोआयोडीन रिफ्रैक्टरी हो जाता है, पेट स्कैन में भी कुछ नहीं दिखता है, फिर भी हम अभी आयोडीन 124 करने लगे. आयोडीन 124 हमारा ही साइक्लोट्रॉन में इंडिया में पहले बार प्रोड्यूस हुआ. सो आई थिंक यू शुड बी ऑल हैप्पी. दिस वाज आई वाज थिंकिंग सिंस लास्ट 10 years. एंड देखिए एक मरीज थायरोग्लोबुलिन बढ़ा था, अल्ट्रासाउंड नेगेटिव है, आयोडीन स्कैन नेगेटिव है, कुछ मिला नहीं, FDG PET कर डाले नहीं मिला, देन आयोडीन 124 किए. आयोडीन 124 में देखिए ये लिम्फ नोड सब है, ये लिम्फ नोड आपको दिखा, ये पैराफेरिंजियल लिम्फ नोड है. नॉर्मली यहाँ लिम्फ नोड वो मेटास्टेसिस नहीं होता है थायराइड कैंसर का, बट यहाँ देखा. उसके बाद हम उसको रेडियोआयोडीन दिए 150 मिलीक्यूरी, देन उसका थायरोग्लोबुलिन 50% डिक्रीज हो गया आफ्टर 6 months. That was the beauty of the technology, I think, but it is definitely costly. हम अभी रिसर्च तौर पे कर रहे हैं with the intramural grant. I think this is the case where it is proven that नहीं तो हम लोग दे नहीं पाते, because आयोडीन स्कैन तो नेगेटिव था. आयोडीन 124 पेट स्कैन जब पॉजिटिव हुआ, हम लोग फिर रेडियोआयोडीन उसको दिए ट्रीटमेंट करने के लिए. बट स्टिल इतने सारा बोलने के बाद भी, इतने सारा करने के बाद भी हमारा देश में चैलेंजेस बहुत है, क्योंकि प्राइमरी केयर उतना इम्प्रूव होना चाहिए. केवल टर्शियरी केयर इम्प्रूव होने से नहीं होगा. आप देखिए ऐसे ऐसे मरीज हमारे पास पहुंचते हैं. शी हैज लॉस्ट हर विजन ऑलरेडी. दिस इज अ फॉलिकुलर सी थायराइड with a skull mets and the eye metastasis. Okay, she must have also multiple bone mets. All these patients still can be stabilized for 5 to 10 years with radioiodine treatment. Even if she loses vision in one eye, the other eye can take care, but you go on repeatedly giving the radioiodine. This is another patient, came from Orissa, because I belong to Orissa, so a lot of people flock to the Lucknow, and you know they look forward. This is a mediastinal shadow. It has not come. Okay, this is a huge mediastinal shadow in the X-ray. This is a metastasis from a thyroid cancer. This patient underwent 4 times surgery in Cuttack Medical College and private hospitals in Cuttack. What is the problem? I will tell you now. Then the importance is, what he used to do. He lives in a village. And he tells his son that मेरे को थायरोक्सिन की टिकिया आप जरूर पहुंचा दीजिए. And the son never used to be so sincere to make his thyroxine available. So he used to make off and on, off and on. So 20 दिन खाता है, 10 दिन उसको छूट जाता है. By this process, it stimulated the metastatic thyroid cancer cell, and it has gone to the superior vena cava syndrome. So मरीज को चलने के लिए बहुत दिक्कत होता है 100 feet भी. But we could not help him and at all, because we could not intubate him in the OT itself. I will show you the CT scan, you will realize iodine was concentrating. आप बोलेंगे कि सर आयोडीन दे नहीं दिए. Okay,
सो आयोडीन सर क्यों दिए नहीं? आयोडीन भी देने के लिए हमको डर लगा क्योंकि 25% इंक्रीज हो जाता है आपकी लुमिनल नैरोइंग में। सो स्टीरॉयड देने से भी बहुत मुश्किल है। सो देन हम सोचे कि ट्रैकियल स्टेंटिंग करेंगे तो हो पाएगा। बट व्हेन द रेडियोलॉजिस्ट एक्सप्लेन्ड फॉर ट्रैकियल स्टेंटिंग एंड टोल्ड द प्रोग्नोसिस की 80% चांस है हम सक्सेसफुल नहीं होंगे, बोला सर 20-30% के लिए हम उड़ीसा से इतना दूर आके नहीं कराएंगे, इधर हमारा कोई मुसीबत होगा तो फिर हम ले नहीं पाएंगे। सो हिज सन डिनाइड फॉर द ट्रीटमेंट। सो दिस इज व्हाट इफ यू don't do in a proper, you see the CT scan of this patient, you see the mass, huge mass, and this is the narrowing. That's why we could not do the you see with this how can you intubate? There is a very hardly a lumen there. Even if you put a pediatric catheter, you cannot really intubate. That's how. मेरे कहने का follow up is very important. Either you come to the hospital और अदरवाइज यू सी 25-30 मरीज एवरी मंथ में ट्वाइस हम टेलीफॉलोअप करते हैं टू कटक मेडिकल कॉलेज। यू सी द क्राउड, दे आर ऑल थायराइड कैंसर पेशेंट्स व्हिच आर फ्लॉकिंग टुगेदर फॉर ए फॉलोअप। सो फॉलोअप इज एक्सट्रीमली इंपॉर्टेंट। थायरॉक्सिन इज इंपॉर्टेंट, रेडियोआयोडीन इज ऑल्सो इक्वली इंपॉर्टेंट फॉर थायराइड कैंसर्स। दैट्स व्हाट यू रिमेंबर, एंड आई थिंक फॉलोअप इज nevertheless. I think this meeting is for lutetium and iodine. I thought I'll close with the therapy, and I think Dr. Suraj knows very well to me that I love therapy, and you see the number of publications in radiopharmaceutical therapy, these are by the beta emitters. Beta emitters means iodine 131 and lutetium, and सारे जो ब्राउन जगह दिख रहे हैं ये सब आयोडीन का जगह है, ये सब ऊपर में ल्यूटीशियम के जगह है। ओके, एंड अदर रेडियो आइसोटोप, हमारा सब न्यूक्लियर मेडिसिन में देयर आर मल्टीपल आइसोटोप, एंड यू सी द पब्लिकेशंस अगेन, दीज आर फॉर अल्फा एमिटर्स। हम लोग तो पहले बीटा एमिटर यूज करते थे आयोडीन 131, अभी अल्फा एमिटर भी आने लगा। जो लोग सब +2 साइंस पढ़े हैं, आई थिंक यू कैन अंडरस्टैंड व्हाट इज अल्फा एंड व्हाट इज बीटा एमिटर फॉर टिश्यू डिस्ट्रक्शन। ओके, एंड if you see by cancer, these are the cancers what we are treating. I think the colorectal cancers, hepatic cancer, liver cancer, breast cancer, prostate cancer, neuroendocrine cancers, thyroid cancer, hematological cancers. These are the cancers are currently already in the vogue for the treatment. I think with this I am closing my talk. Thank you very much for patient listening. एनी क्वेश्चंस? आपकी कुछ भी आपकी दिमाग में है तो आप हमको पूछिए, हम बता देंगे। ठीक है? आप सोचते हैं कि नहीं सर ये कैसे कॉम्प्लेक्स हो जाएगा रेडियोआयोडीन ट्रीटमेंट, बहुत सिंपल है। यस, अभी रेगुलर उतना नहीं। वी बेसिकली वंस यू सेंड ए पेशेंट, विल गिव हिम ए डेट and then we schedule for the iodine 124 PET scan. And many people might be thinking it is easy. I dreamed for 7 years because there was no money in the research of 1 lakh, then became 3 lakh, then became 5 lakh. When it became 10 lakhs from my institution, I went to the research committee that you please give 10 lakhs rupees for the iodine 124. So the director asked me, do you really anybody does in India? I told no, nobody does. I told sir इंडिया में नहीं होता है तो कहाँ होगा? तो कोई करेगा नहीं, कोई तो करेगा। तो मैं बोला सर आप पैसा दे देंगे तो हम कर लेंगे। Then they gave the total fund 100%, 10 lakh is the maximum limit, they gave 10 lakh, but unfortunately this is very costly. 9 lakh, 9.5 lakhs has gone to the metal target itself. So the production and everything, and it is cumbersome, and it is people are not able to do India because we have a very high energy cyclotron which is the best cyclotron in the country. That is called 18 mega electron volt cyclotron with a solid state technology. इसीलिए हम कर पा रहे हैं। अभी सूरज मरीज भेजेगा तो जरूर करेंगे। The half life is 4 days and it is given orally. Okay? So now many hospitals in the country are asking me, can you give us radio iodine 124 because ये 4 days half life है, तो हमको ट्रांसपोर्ट करके दीजिए. लेकिन मैं बोलता हूँ कि हमारे लिए पहले हो जाए, because we are not able to produce as much. We are just in the research mode, we have not offered to the clinic. तो बट स्टिल जो मरीज को रियल जरूरत होता है हम जरूर करेंगे. थैंक यू. Yes, yes, he wants to ask.
Sir, nowadays heart attack are very common in everywhere. Na? So my question is that suppose if any patient is having high dose therapy treatment and at the time he is getting cardiac arrest, so how do we manage code group protocol? And in second scenario, if the patient is dead, so in which case if there is need of autopsy or which precautions we will take if the patient is dead, handling to the attendant and other things?
I think in cardiac arrest, if suddenly patient develops the heart attack, the first priority will go that you must go and take a blood sample. Within hardly 2 minutes you can take a blood sample and do a troponin test. Okay? That really doesn't give you the barrier that you cannot access to a patient. You have lead sealed and you just take the sample. What is the problem? But all these patients, when you have given suppose 200 millicurie to a metastatic patient, so obviously there is radiation, but nevertheless it is not. Hardly in my whole life I have not seen to date that I cannot access. I remember once in the night I came from my home to the SGPGI because one patient who had lung metastasis with a pleural effusion and there was a pneumothorax, so they put a sealed drainage tube, and because of the patient was a little disoriented, what he did is he pulled it and now whole pleural fluid came in the ward. So my resident started trembling, saying something wrong went, I think sir will scold, and he called me over the phone in the night. When I came, I told you don't have to worry that it is so much radioiodine is really exposing yourself and you are utilizing your badge. You will not get exposed so much. Regarding the cadaveric, suppose a patient dies and you have given 200 millicurie or 150 millicurie. It's a higher dose if you have. These 30 millicurie will never, 30 millicurie is how much? It is just if you give 30 millicurie, it is allowable for OPD basis. You see, it is at 1 meter, you should have a 5 milliranjan per, okay? That much radiation is acceptable. So, but if it is more than 100 millicurie or 200 millicurie, definitely you need to take care. That cadaveric situations is RSO and also the physicians. Both should take the combination of decisions, so you don't have to really worry for this radiation ad. Okay? So that precautions you can easily take and you can go for the burial or the, okay? So that is possible. That's possible. That's not a difficult job at all. Only thing what I will suggest is, I think this is for you as well as Dr. Suraj, whoever it is treating. Patients who are hypothyroid grossly, sometimes I have had one patient I have had in Mumbai. The patient, because of the severe depression because of hypothyroidism, he made a suicide inside the room, okay, even if taken radioiodine. So these are the anticipations which can come extremely occasionally. I have never faced till today. But I have faced these patients when they are hypothyroid, they sometimes met with accidents. So what I say to the patients, if you are a stockbroker, if you are a chartered accountant, if you are a driver or if you are a pilot, please use the recombinant human TSH if you can afford. Okay? Or you can treat them with moderate hypothyroidism, not stopping for 4 weeks, you can stop for 3 weeks and measure the TSH and do the radioiodine therapy. Okay?
Thank you. Thank you.
Thank you so much, sir, for these valuable insights. Now I would like to request Dr. Ankita Patel, ma'am, to please felicitate Dr. P.K. Pradhan, sir.
Because he is the man who has to do it.
Now I would like to invite Dr. Ajay Singh Suraj, sir, consultant nuclear medicine, Apex Hospital, to give a talk on high dose iodine 131 at Apex, workflow, isolation and discharge, radiation safety checklist and follow-up.
Good evening, everyone. As most of the part of the iodine 131 therapy has been discussed by our previous speaker, so I will only emphasize on the radiation and isolation. So first, we can see what is radio iodine 131. So it is an isotope with having half-life of 8 days, which decay by beta and alpha emission. So the beta emission destroy the tissue which have the limited range, maximum up to 2 mm, and gamma emission used to imaging. So that's why it's called theranostic. Therapy plus diagnostic means theranostic. Radioactive iodine usually supplied as the sodium iodide, and it is given by oral route, because most of the radioactive therapy is given by the IV route, but the only iodine is thing that it is given by the oral route, either by capsule or in the form of liquid. So why iodine 131 is ideal for thyroid? Because it selectively uptake in thyroid tissue with the NIS means sodium iodine symporter, and it deliver the radiation to the target tissue and limit the damage the adjacent surrounding tissue. And what is the route of excretion? So almost all excretory organ of the body excrete radioactive iodine 131, like it excrete from the nasal secretion, saliva, urine, sweat, GI feces and milk, breast milk. So when we give, so what is the pre-therapy whole body radioactive iodine scan? We usually use 2 to 3 millicurie for the scan, and scan is done after 48 hours of oral administration. So what is the prerequisite? Prerequisite is TSS should be more than 30. It can, because it stimulate the thyroid follicle cell, and it can be achieved by the thyroxine withdrawal or recombinant TSH. And other prerequisites are should be optimal blood profile and renal function. So after giving the therapy, why isolation is required? So as per Atomic Energy Regulatory Board, any therapy which is given more than 30 millicurie iodine, it should be considered a high dose therapy and should be patient isolated from the general public. So, and why do that patient is isolated? Because of the gamma radiation. It is not by the beta. So purpose of isolation is prevent radiation exposure to the hospital staff, other patients, family members and general public. Also to control the radioactive contamination, that is urine, saliva and sweat. So we have a isolation room which is dedicated for the radioactive iodine patient with attached toilet, impervasive flooring, lead shielding, radiation warning signage outside and restricted entry to the other than nuclear medicine personnel. We give usually patients for during the isolation, we instruct the patient to maintain 2 meter distance from staff and stay inside the designated room. When use toilet, at least flush 2 to 3 times after use and hand wash thoroughly. And for personal hygiene, patient should bath daily and use a separate towel. And should eat in a disposable utensils and avoid the food sharing. For staff precaution, we use ALARA principle, that is as low as reasonably achievable, that is time, distance and shielding. So we have to minimize the time, maintain at least 2 meter distance and use the shield, this is the lead shield. Apart from this, also staff should wear gloves and clothes cover, wear TLD badge and strict prohibition of the pregnant staff. During isolation, we should monitor a radiation exposure at 1 meter according to International Atomic Energy Agency guideline. So, and also for check contamination and minor symptoms, that is nausea, vomiting, neck pain and silidinitis. For waste management, it is most crucial part of the isolation. So when the patient admit in the radiotherapy in the radioactive therapy ward, so we have to monitor every thing that come outside from the patient. That is solid waste. We should put this waste in the lead bin. This is the lead container for 80 to 90 days. Why 80 to 90 days? Because radioactive iodine have a half-life 8 days. We should store for at least 10 half-life. That is 80 to 90 days. And linen means bed sheet. Bed sheet of the patient is also stored for the 90th day. After that, we have to check the radiation. If it is within the limit, then send to laundering. And liquid waste means patient excreta and urine is also stored in delay tank. We have a 2 delay tank, each capacity has 6,000 liter, in which we delay and decay, means as time begins the radioactive will decay. When the radioactive will decay with the certain limit, then we have to discharge to the normal sewage plant. And our RSO will check the radiation limit of these tank material. If it is 1 microcurie per liter, then is the condition that we can discharge the effluent in the normal sewage. About patient discharge, the exposure rate at 1 meter should be 1 millirem per hour. After that, we have to give a written instruction for the radiation safety and the documentation for the radiation that the patient is emitting radiation below the normal limit. So usually isolation duration is 1 to 2 days for 30 to 100 millicurie, 2 to 3 days for 100 to 50 millicurie, 150 millicurie, and 3 to 4 days for 150 to 200 millicurie. Before discharging the patient, we do a post-therapy scan. It is more sensitive than pre-diagnostic scan because we give a high dose of radioactive iodine. It may detect the additional lesion and change upgrade the staging. So may alter the future RAI dosing. So the radiation safety checklist, so very important, patient should not pregnant. So we have a negative pregnancy test within 72 hours, and patient should be not a lactating woman. And lactation, stop breastfeeding at least 3 months before radioactive iodine therapy. And no plan of contraception. Women should avoid pregnancy at least 6 months after the radioactive iodine therapy, and men should avoid fathering a child at least 4 months after iodine therapy. And patient assessment, the second checklist is the patient assessment, and patient should be able to follow the instruction, maintain isolation, and should have no urinary incontinence. And third most important, that the counseling. We have to counseling about the time, distance, hygiene principle, contact limitation, especially with child and pregnant women, hydrate well and void frequently, wash the hand thoroughly. Now come to the adverse effect of radioactive iodine therapy. The short-term effects are mostly nausea, vomiting, or temporary salivary gland pain. And long-term effect is dry mouth, and rare is secondary malignancy, which occur usually more than 1,000 millicurie. I have seen only one case in my lifetime. So it is not a common thing, it is very rare. So what we do in our Apex nuclear medicine department, when patient come to our department after total thyroidectomy and lymph node dissection, we just do a American Thyroid Association risk stratification. After that, we will, if there is need to give the radioactive iodine, we will proceed to pre-therapy workup and TSH stimulation. After after oral administration of the radioactive iodine, we just put the patient in isolation room. If the exposure is below, if the exposure become below 5 mR per hour, then we will discharge. Before discharge, we do a post-therapy scan. After that, we send the back and do follow-up. Thank you.
Thank you so much, sir. Now I would like to request Dr. P.K. Pradhan, sir.
Sir.
Female patient with reproductive age, and she is planned for high dose radioactive. So does there is effect on reproductive organ?
In low dose means
The limit of gonadal cells are very low.
so usually 800 millicurie. It is given in guideline. If up to 800 millicurie, there is no significantly outcome in the reproductive outcome, because there is only mild changes in the ovaries. So it is recommended that for female patient there is no significant change after giving the radioactive iodine therapy. In male patient, there is now in 2016 to 2026, there is a recommendation if you are giving cumulative dose more than 400 millicurie, then there is some change in sperm morphology. So we have to, it is generally advised to do a sperm banking.
एक चीज है कि जो आप व्हाट इज द इफेक्ट ऑन गोनाड्स normally for both male and female we just want advise them, counsel them not to have a plan for pregnancy, okay, for next 3 to 6 months, okay. If somebody says no, I just want to plan the pregnancy quickly, we say you have a malignancy, so little wait. Once we say that it is free of disease, the tumor markers are normal, there is no structural disease, and we are little assured, then we allow the pregnancy to go, but minimum after 3 to 4 months, minimum. That means planning pregnancy. We also go to that extent. If somebody is planning pregnancy, we counsel also when we treat, that we advised 5 milligram of folic acid to prevent the neural defects also, okay. So the recent guidelines, what is showed, that is because there is a transient oligospermia or azoospermia occurs, and the motility of the sperms are a little impaired, okay. That's the reason for which giving a gap also in male for 3 months, okay. That means minimum 4 to 6 months we have to wait. We just cannot quickly go for pregnancy. If somebody plans a pregnancy, then it is too much delayed. Like you will plan a pregnancy, there will be children give birth to the child, then again the lactation will be there. So I always say you wean the child, then bring for radioiodine. Waiting for 3 months, it is not analogous to breast cancer or any other cancer. These are slow growing cancers, okay. We can wait for 3 to 4 months, there is no harm about it. That's why many surgeons sometimes say me, sir, this is urgent, patient has cancer, you have to give a quick date. I told you, go to the guideline, you don't have to give a quick date unless until there is a pressing symptoms caused by the metastasis, okay. For remnant ablation or for treatment, still the patients can plan within 3 months period, easily.
I would now like to request Dr. C.P. Verma sir to kindly felicitate Dr. Ajay Singh sir. Our next speaker for today is Dr. Puneet Kumar, KM, Consultant Urology and Kidney Transplant Surgeon at Apex Hospital, to talk on the topic, who should undergo surgery, risk stratification in prostate cancer. He would be joining us online.
Hello, am I audible?
Yes, sir.
Yeah, okay. So, great. So, good evening to all. So, it is my pleasure to at least to have an opportunity to present online on the topic which we are very versed in treating the patients. So, congratulations to Ankita madam and the nuclear medicine department for starting the both iodine and the lutetium therapy. So, In the next few slides, I will just concentrate on which are the right candidates for the prostatectomy in a case of CA prostate, because CA prostate is such a vast topic, from active surveillance to surgery, radiotherapy, and now the lutetium therapy. So it is a very vast topic. So I will, based on the guideline recommendation, I will just touch upon the candidates who are the right candidates for the prostate surgery. In the last past 2 to 3 decades, there is a evolution of robotic surgeries which is making the surgeries more safer and less morbidity. So with this advancement, obviously the indications for surgeries and reaching out to the prostatectomy has also increased. So in this setting, so not only the localized cancers, even the oligometastatic cancer also in under trial, they are now subjected to the prostatectomy. So first and foremost, when there is a suspicion of cancer, you have to diagnose the cancer by multiple modalities, either examination, PSA, MRI, and all those things. Once the diagnosis is, as with any other cancer, we have to stage the cancer according to the TNM classification, whether it is T2, T1, 2, 3, 4, and what is the nodal status and what is the metastatic status. Because all this status staging depends the treatment and the outcome. So first is diagnosis, second one is the staging. So once the staging is done, so you have to risk stratify, because based on risk stratification only the different modalities of treatment will be explained to the patient and the relatives. It is because an active role is there also about the patient and their relatives in the treatment of CA prostate. So risk stratification and giving all the options, available option to the patient and the families of paramount important in cancer of prostate treatment. So there are multiple risk stratification, but most commonly used is the DMAQ or NCCN guidelines risk stratification. So in detail, even Dr. Ankita Madam will be touching upon. So with respect to the surgical points, I will just brief on the candidates with respect to the risk stratification. So there are mainly 4 broad risk categories: low, intermediate, high, and very high. Based on, we risk stratify the CA prostate patient based on 3 things, that is serum PSA, Gleason score after the biopsy, and according to the TNM staging. So what are the levels of this PSA, what is the grade of the Gleason score, and what is the TNM? Based on this, patient will be allotted to the risk group. So when it comes to the low risk, who comes under the low risk? So PSA less than 10, Gleason less than 6, and low clinical stage, that is either T1 or T2A, means the tumor should be in the one half of the gland only. Then it comes under low risk, and means disease is less and patient is fit for surgery. So this is a definitely a clear-cut case of for prostatectomy. These are the patients which cannot be denied prostatectomy. This has to be upfront given the option of surgery. So when you move on to the next category, that is the intermediate. In intermediate, they have divided it into favorable and unfavorable based on the Gleason scoring. In that also, what you have to consider mainly is whether the patient is fit for surgery and whether he can live another for 10 years. What is his general condition? Based on that, you have to consider whether we can offer him prostatectomy or not. Main thing what you have to look is what is his good life expectancy. So next, when there is unfavorable points, like if Gleason score is increased in 4+3 or multiple intermediate factors are there, that like PSA is more than 10 to 20. So then you can consider surgical prostatectomy. Along with that, pelvic lymph node dissection is must. But meanwhile, you have to counsel him for the multimodality treatment. So from the unfavorable intermediate group onwards, patient will not be subject only for surgery. It will be a teamwork. It will be offered a multimodality treatment. So after the prostatectomy, patient has to be counseled for adjuvant or salvage treatment. So there is a limited or some amount of role of prostatectomy and high and very high risk group. So high and very high risk groups are mainly those who have a T2 disease, means prostate, the CA is already there in the both the lobes. So they comes to the high risk and very high risk and with a high PSA value like more than 20 or high Gleason score more than 8. These are all the candidates for both RT and RP. But if you are selecting for RP, you have to select very carefully and you have to offer extended pelvic lymph node dissection
And again, once the recurrence happens or relapse, we have to offer him the multimodality treatment. So in high and very high risk, the patient selection is very important. What is the role in regional prostate? Previously, we used to say it as a locally advanced or disease when there is a node positive. Now it is called a regional prostate CA. So apart from the T stage, if any node is positive, is N plus, and patient is, you can expect more than 5 years. Even then, the RP in selected patients is the option in this patient. So in a regional prostatic cancer. So, and what about the metastatic cancer? After that, there are many trials are going on. If an oligometastasis, less than 5 metastasis in the bone, even there is a role of radical prostatectomy, but still it is not in the literature, it is still in the study stages. So it is in metastatic prostate, definitely it is again a multimodality treatment, surgery has a very limited role. So what are the contraindications as for surgery, as with any other surgery? If patient is having a poor general condition, poor life expectancy, severe multiple comorbidities, heart disease, and if he is unfit for anesthesia, so this is a definitive contraindication for the surgery. So the bottom line is, according to NCCN, when you are going to consider surgeries, preferred candidates are definitely low and intermediate risk with a good life expectancy. You can consider in high and very high risk as a part of multimodal therapy, and only few selected patients as a part of studies in cytoreductive surgeries, or if the patient is having recurrent hematuria as a part of multimodality treatment, he can consider surgery. So where you don't do is, if the patient life expectancy is poor, severe comorbidity, you never consider surgery. So conclusion is, surgery is standard in localized disease, and it can be a part of the multimodality treatment in high risk cases. Proper risk stratification is very much essential, and in CA prostate, individual patient selection and individual patient treatment is of paramount important. So this is one of the case what we have done recently. The patient has a high risk case, but he had a hematuria and he has presented with AKI. So in this setting, definitely minimally invasive laparoscopic prostatectomy has offered him a good care, and definitely CA prostate is a teamwork. So with this, I end the presentation and wish the team a good luck.
Sir, any questions from your side? Thank you so much, sir. Now, the next speaker for today is Dr. Ankita Patel, ma'am, Consultant Radiation Oncology, Apex Hospital, to talk on the topic prostate cancer and brief role of radiotherapy and practical treatment pathways for MCS-PC and MCR-PC.
So good evening everyone. I will be briefly touching the aspects of radiation and also castration sensitive and castration resistant prostate cancer. Where is Sonashri? Caller. Okay. So just screen shared. So, I'll be basically discussing as per NICE guidelines, UK guidelines. There are slight differences between various guidelines, so my presentation is basically based on NICE guideline because time does not permit entire discussion. So whenever the prostate cancer patient presents in clinically in OPD, the first thing we need to do is stratify the patient, whether it's low risk group, intermediate or high risk. So low risk should include all the three features: Gleason score 6, stage T1, T2A and less than 10 PSA. So all the three criteria must be met for low risk. And for intermediate or high, any single criteria qualifies. So intermediate, if the Gleason score is 7 or it's T2B, T2C and PSA 10 to 20, and high 8 plus, T3A and more than 20. So this should be imprinted in everybody's mind when the patient enters OPD. Now coming to low risk prostate cancer. So in low risk prostate cancer, we have all the options. We can go ahead with active surveillance, wherein close monitoring with deferred treatment, seed brachytherapy in select patients, permanent implant low dose rate seeds, EBRT, external beam radiotherapy, robotic assisted laparoscopic prostatectomy and waitful watching with PSA monitoring only. Now there were two trials, PROCTED trial, it was phase 3 trial which enrolled 1600 men comparing RP, RT and active surveillance with repeat biopsy if PSA rises to above more than 50%. 10-year follow-up shows no significant difference in cancer-specific survival in 99% of all three arms, but there was caveat in active monitoring, statistically significant increase in skeletal mets and need for ADT in surveillance arm. Pivot trial, it also shows that when we compare RP with waitful watching in select elderly low risk patient, there is no risk in OS difference. So prostate cancer is a slow growing cancer and it is usually detected in elderly. So we have to stratify the patient. We don't want to give treatment with morbidities. In prostate cancer, even if we closely, low risk patients, if we closely monitor the patient can live long with active surveillance or with ADTs. Now what is active surveillance? Now active surveillance, it postpones treatment and its complications. Any change in PSA or DRE results trigger in restaging investigation. So we have to do three things. First, when the patient presents, multiparametric MRI mandatory, then every 3 to 6 monthly PSA plus digital rectal examination and biopsy and or MRI at 1 year. While doing this, if there is any change in PSA or digital rectal examination, it should be restaged and treatment should be given. Now seed brachytherapy. We cannot, so it is basically for low risk patient. In select patient, what select patient? T1, T2 and life expectancy more than 10 years. Gleason score should be 6 and PSA less than 15, and if Gleason score is 7, PSA should be less than 10, and prostate volume should be less than 50. If the prostate volume is high, we can give ADT, reduce the volume and then do seed brachytherapy. Also, we need to see the urinary function. Qmax should be more than 10 ml per second. If it is very high, the seed may come out during urination. So these all factors, so that is why very select patients are eligible for seed brachytherapy. Now radiotherapy is one of the potential option in low risk. Now about fractionation. So there was CHIP trial which investigated conventional versus hypofractionated IMRT for prostate cancer. So initially we used to give 74 gray, then we reduced to 60 gray, and in this CHIP trials 57 gray was also tried. So eventually now we are giving 60 gray because 60 gray is non-inferior to 74 gray. So this is hypofractionated arm, so this is now standard of care in prostate EBRT. If you are going ahead with conventional dosing, it's 60 gray in 20 fractions, moderate hypofractionation. So now coming to intermediate risk prostate cancer. So in low risk we have all the options. Intermediate, there is slight limitation. Active surveillance only in select cases in elderly patients if they are wishing to postpone the treatment. Prostatectomy, better quality of life for fit, surgery for fit younger men with lower urinary tract infection. If the patient is presenting with urinary infection, radiotherapy cannot be first option, because if there is infection, there will be fibrosis, lot of reaction. So if any patient with infection, definitely EBRT has to, we can wait for EBRT. In intermediate risk, robotic prostatectomy can be the standard of care. If not, then seed brachytherapy is also option. EBRT with 6 months of ADT or HDR EBRT. HDR is high dose radiotherapy, that is basically brachytherapy, plus 6 months of ADT. So in intermediate also we have all sort of options depending on patient's comorbidities and infection status. Now what are the contraindications for radiation? If the patient has received radiation prior for any other disease, we cannot give radiation. If patient is having inflammatory bowel disease, we cannot give radiation. And if there is bilateral hip replacement, because during CT scan, RTP scan, there will be lot of artifacts and also there will be slight change in dose. So that is, these are the relative contraindication. What are the indications in intermediate risk? If the life expectancy is more than 10 and men over 75 with minimal comorbidities. So we can choose between surgery or radiation depending on various factors. Now coming to high risk. In high risk patients, radiations become the more potential and more tolerable treatment options. So robotic prostatectomy in well selected patients, the better options are ADT, that is anti-androgen therapy for 18 months plus EBRT. So we start with ADT, give for 2 to 3 months, downstage the disease, and then give EBRT, complete EBRT, and then again give for 2 years. Seed brachytherapy plus EBRT, combined brachytherapy boost in very, very selected elderly unfit patient with life expectancy less than 10, waitful watching can be an option, and this is also potential option, ADT plus chemotherapy plus EBRT. So we just have to remember, patient coming, we have to stratify the patient, then note down the comorbidities, note down the infection status, note down the urinary function status, and then decide what treatment is best fitted for the particular patient. Now various fractionation schedules. So normally we practice 60 gray in 20 fraction. For low or intermediate, if we have SBRT facility, we can give 36.25 gray in 5 fraction, which we are doing in few patients, or hypo RT-PC 42.7 in 7 fractions. But if it is high risk, node positive, we need to give 60 gray in 20 fraction or 74 gray in 32 fraction. This is preferred and most routinely used fractionation schedule. Now, post-operative radiotherapy, patient going to uro-oncology, got operated, came to us with report. Now, when to check PSA? Shri, when to check PSA? Patient coming after prostatectomy, when to check PSA? To see the result. Always check PSA after 6 weeks. If we are checking in between 4 weeks, 5 weeks, it might be higher. So it should be checked ideally after 6 weeks. Less than 0.01 is ideal, less than 0.1 is also acceptable. Now, if there are high risk features, like if T3 positive, Gleason score more than 7, R1 resection. So these are the indications for adjuvant RT. But now according to Radical's trial, if the patient is of high risk category, but PSA is less than 0.2, we can keep patient on close surveillance, keep monitoring PSA. If in case it rises, then we can give salvage RT. So this will reduce the toxicity given to the patient, because many of the patient will never reoccur. So if the patient PSA after surgery is 0.2, RT has to be given. If PSA is less than 2, Even with high risk factors, we can wait and closely monitor PSA. If PSA rises, then we can give salvage RT. Now, coming to metastatic prostate cancer, castration sensitive, just here. This is a very nice slide which I have taken from Leeds. So, if the patient coming is newly naive diagnosed, naive patient, metastatic, hormone sensitive, the first thing which we have to see is the performance status. If the patient's performance status is more than 3 and there are significant comorbidities, we have to give ADT or best supportive care. So, in hormone sensitive patient, ADT is the backbone of the therapy. Now, we have to stratify as per the performance status. If the performance status is more than 3, significant comorbidity, best supportive care along with ADTs. ADTs do not have much toxicities. If performance status is good, it's 0 or 1 or 2. Now, these are the options. We can give ADT plus docetaxel, ADT plus enzalutamide, ADT plus apalutamide, ADT plus dosi plus darolutamide, which has got recently approved, very recently. So, these are the options. If the patient is failing in dosi, we can give enza. So, this chart you have to keep in your mind. Now, there can be few patients with low metastatic disease burden, matlab oligometastatic. The patient might have prostatic disease with few metastatic lesions. So, we can go ahead with SBRT to metastatic lesion and RT to prostate 36 gray in 6 fraction. So, this will also yield good result. So, this was all about castration sensitive, metastatic hormone sensitive prostate cancer. Now, the next slide will be about castration resistant prostate cancer. Patient coming to us and has already received some kind of treatment. The patient can be metastatic or non-metastatic. Suppose patient is non-metastatic, performance status is 0 to 2. We can give, so these are the preferred option, darolutamide or apalutamide. In case patient develops eventually metastatic, then we can go ahead with docetaxel. If failing on docetaxel, cabazitaxel and then lutetium, vice versa. If the patient is metastatic castration resistant prostate cancer, now we have to see whether the patient is symptomatic and rapidly progressing disease with liver mets, lung mets, lots of symptoms. Always start with docetaxel, because chemotherapy will always yield rapid response. In case the patient is metastatic but minimal or low symptom, no symptom, we can go ahead with abiraterone or enzalutamide. If we have started with docetaxel, if the patient progresses, we can switch on the therapies. We can go ahead with lutetium, we can go ahead with cabazitaxel, we can go ahead with enzalutamide. And if the patient is having no symptom, we have started with enza, progressed on enza, we can go ahead with docetaxel followed by cabazitaxel. So, we have few options. We have options of ADT, we have option of chemotherapy, we have options of some targeted and these receptors, anti-androgen receptor molecules. So, we have to very religiously first categorize the patient according to the performance status, comorbidities, and also see what is the kind of disease, rapidly progressing, symptomatic or minimal or no symptoms. Also, if the patient is usually coming with bone mets, don't forget to give zoledronic acid or denosumab. And in case patient is coming and patient has already received docetaxel or enzalutamide, we have to always start with the agents we have not used. So, this is a very simple chart, and you can select the patient and go ahead with this flow chart in your regular OPDs. So, I am not going ahead with all the trials because that will be very exhaustive and not in contest with this particular CME. So, thank you so much.
What is the role of, you see, I'll give you one example. A patient with around 66 years old, and the Gleason score is 7, with lymph node metastasis only to the mediastinal lymph node, which we could not prove with sampling because he himself is a doctor. He didn't agree for the sampling. He wanted that, he came to us directly saying that I want Lutetium 177 PSMA therapy. Okay. Then I told, why don't you take an opinion from urology or radiotherapy, saying then we'll see, or otherwise you go for sampling. Okay. What's your opinion to treat these patients with at that? He was, yes, CA prostate on ADT, on abiraterone, but still the PSMA scan, because nowadays patients are mostly not they are asymptomatic. But they will, once the PSA starts increasing, so obviously they go for gallium-68 PSMA scan. And the gallium-68 PSMA scan showed that there are mets in the lymph nodes, in the mediastinum. And no, PSMA was positive. So obviously I thought, what is your choice for chemotherapy now with a cabazitaxel or a docetaxel? Or we want a lutetium PSMA therapy?
So for lutetium, I don't have personal experience, I cannot comment
Okay.
on it.
Okay.
But if the patient is on ADT and then progressing on ADT, the second option is always docetaxel before cabazitaxel.
Okay.
We proceed
Okay.
like dosi, then cabazitaxel.
Cabazi.
Cabazitaxel after dosi is usually not given.
Not given.
All the
That's
guidelines, always dosi and cabazitaxel. That is the only option.
what we did is we offered him after the urology consultations, because the urologist told, sir, you know everything over phone, then why you are sending to urology? I told, I am just sending because I am going away from the standard of care. Okay? Because there is no internal iliac or obturator or any pelvic, locoregional meds are not there. That is directly, which is a little unlikely to the likely mediastinum directly.
So is it confirmed it is prostatic lesion only?
Oh, I'll tell you the story then.
Sorry, like EUSN biopsy or FNA?
No, we didn't do anything. My colleague also didn't agree to treat. I told the patient is demanding for lutetium PSMA, let's treat. Okay? We treated and the lymph nodes in the mediastinum went off. Okay? PSA came down drastically and it became 0.1. And subsequently, what he thought, because he is a doctor, he demanded for surgery of the primary prostate now. But I explained to him that please don't go for surgery because it is a metastatic disease. Even if you are on ADT, abiraterone, then lutetium PSMA, though we have taken care, 3 cycles we gave, and the PSA become normal, 0.1, and the lymph nodes went off with a gallium-67 8 PSMA scan, that is called interim PET scan after 3 cycles. Okay?
So, I think this is oligometastatic disease, basically.
Yes.
Oligometastatic, if there is good response and if patient is willing, with patient consent, like we have what the guidelines say, we can go ahead with RT, 36 and 6th grade, to prostate and SBRT to the lesions.
Okay.
If the patient is okay, if the surgeon is okay, that can be done, considering it as an oligometastatic disease.
But you see the pathetic part of the story. I denied for any kind of treatment. I told it is 0.1. You complete your cycles, another 3 cycles, lutetium, and then that will take care of the micrometastasis if at all there. But he didn't agree. He has his own thought from the literature. What he went is he went ahead with the robotic surgery. Okay? I only suggested him, you go to best centers and take your opinion. And it is unfortunate that following the robotic surgery, he developed a vesico-rectal fistula. Okay? See the story, how the difficult it is. So then subsequently, now after a year and a half, recently I saw the PSA starts rising and the gallium-68 PSMA scan again shows the same lymph node in the mediastinum.
So the moral of the story is go ahead with less interventional
Yes.
treatment.
Yes.
Don't use all the armamentarium in like one.
Yes. But the best part of lutetium PSMA now is, you can see the literature, earlier we are the last line, now we are the first line. But the reason being why people are opting for lutetium PSMA is, the targeted radionuclide therapy with lutetium PSMA for prostate cancer is hardly any toxicity. That's the reason for people really demanding for this treatment. I think it's beautiful. It's beautiful. Thank you. Thank you.
Thank you so much, ma'am, for such thought-provoking talk. Now, I would like to request Dr. P.K. Pradhan, sir, to kindly felicitate Dr. Ankita, ma'am. Now, I would like to invite our next speaker for the day, Dr. Abhiram, MD Nuclear Medicine and second year radiology resident at Apex Hospital, to talk on the topic 177 lutetium PSMA radioligand therapy in MCRPC.
Good evening, everyone. I thank the Apex Hospital and Dr. Ankita Madam for giving me the opportunity to speak. It is my privilege to speak in front of esteemed colleagues. Today I would be talking on lutetium-177 radioligand therapy in metastatic castration-resistant prostate cancer. I would basically be discussing some guidelines from EANM and SNMMI. Once again, I thank Apex Hospital and Dr. Ankita ma'am for giving me the opportunity. So this is the presentation overview. Coming to the background of PSMA biology, initially the PSMA receptor was discovered around 2000, where it was a folate hydrolase enzyme, and antigens were targeted to the folate hydrolase enzyme. Over that, they identify that in prostate cancers, the PSMA is overexpressed by 100 to 1000 times. There was an inverse correlation to the androgen receptor, and it was very ubiquitous to metastatic prostatic cancers. So how does lutetium PSMA work? There is expression of PSMA on the prostatic cancer cells. The lutetium PSMA through a ligand, which is either HB-EDCC or DOTA or any other ligand, binds to the antigen and it is internalized. Once it is internalized, the lutetium-177 releases the beta. Beta has the cutting ability. The cutting ability is around 2 mm. The maximum beta energy is around 0.5 MeV. The half-life of lutetium-177 is 6.7 days. So we have the gamma emission also, by which lutetium decays, which is useful for imaging. And post-therapy, the SPECT imaging is done for detection. So with the lutetium-177 dotatate therapy, the concept of theranostics had already set in the late 1990s, and that was further extended into lutetium PSMA therapy. Initially, the diagnostics was done by targeting the PSMA antigen. Later, the concept of lutetium-177 PSMA therapy came about. When I was resident in PGI in 2015, we were doing the diagnostics. By the time I got out from PGI in 2017, we had already started the therapy. In 2012, the first history of PSMA imaging came from Germany. After that, the PSMA therapy came about in around 2015. So regulatory approval and clinical evidence, the phase 3 randomized control trial was performed by the Vision trial, which included around 700 patients, around 800 patients. It was published in New England Journal of Medicine. The final publication was done in 2022, after which in US FDA regulatory approval was obtained and Pluvicto was approved for the standard of care in metastatic castration-resistant prostate cancer. In the Vision trial, it showed that there was a median overall survival of 11.3 months, median progression-free survival was 8.7 months, and PSA response was 29% decrease, and number of patients included in this study was 831. So what was the patient selection criteria in that? The major inclusion criteria included metastatic castration-resistant prostate cancer, patients who have progressed on taxane or one novel androgen axis drug, PSMA positive disease on PSMA PET CT scan. There must be adequate end organ function, renal, hepatic and adequate hepatological function, ECOG performance status of 0 to 2, and castrate testosterone level should be less than 50 nanogram. What is the exclusion criteria? Usually when PSMA is negative or significant PSMA discordant disease, prior lutetium therapy or other beta emitting agents, severe renal impairment where GFR is less than 30 ml per minute, there is active bone marrow failure or infiltration in terms of pancytopenia, serious active infections or concurrent illness, patient is pregnant or there is ongoing breastfeeding, and urinary incontinence requiring catheter. How is the image stratification done? Initially, PSMA PET CT is done. Either it can be a gallium based PSMA PET CT where PSMA 11 is used, or an F18 PSMA scan can be done. It is mandatory. It is not mandatory to perform before each cycle. It can be performed just at the start of the therapy planning, and later beyond 2 to 3 cycles for further interim response assessment, and at the end of 6 cycles a final complete response assessment can be done. A PSMA expression assessment of the entire whole body is done. The physiological uptake in the liver, spleen, salivary glands and others is identified to see adequate labeling, and post that the uptake is compared to that of the liver to see if there is adequate expression of PSMA, and then we can plan for PSMA therapy. Bone scan and CT scan remain essential alongside PSMA PET, but with the improvement in the PSMA PET CT imaging, these are now becoming obsolete, and response assessment is mainly done with PSMA. Bone scan and CT scan is done in those places where PSMA PET CT is not available. So what is the treatment protocol? The main standard agent is lutetium PSMA 617, which is used. The dosage is around 200 millicurie. The dose can be reduced depending on the conditions. If there is renal impairment, we can give up to 150 or 170 millicurie, and even in case of oligometastatic disease, the dose may be reduced, although there is not much clinical evidence in that, because all stage 4 metastatic cancers require higher dose, but in case of oligometastatic disease, the dose can be reduced. The cycles is up to 6 cycles every 6 weeks, and it is given by slow IV infusion over a period of 30 to 60 minutes. What are the pre-treatment requisites? High fluid intake to maintain adequate hydration levels, laxatives to reduce bowel radiation, verification of the complete blood count, creatinine and PSA at the baseline for further follow-up of the patient. Comprehensive radiation safety counseling has to be done, and antiemetics may be needed because there might be some electrolyte disturbances, or because of the alteration in the protein interaction because of the lutetium PSMA which happens, there might be triggering of vomiting, so antiemetics are necessary. Observation of around 2 to 4 hours is essential post infusion. It can be done as an outpatient procedure, and the approval has been given by the ARB recently. Salivary gland measures to reduce the sialadenitis and radiation protection to the salivary glands. Radiation precautions not as exhaustive as for iodine, but still need to be taken. Maintain high fluid intake even after post infusion, so that non-target radiopharmaceutical is excreted out of the body. SPECT imaging is optional, but usually done within a period of 7 days. Can be done within 24 to 48 hours, ideally when the patient is within the hospital. PSA needs to be assessed at each cycle. Imaging or restaging should be done after 2 to 3 cycles. It can be continued if the patient is stable or responding. If there is any toxicity, the cycle can be delayed. And if there is progressive disease, multidisciplinary tumor board discussion has to be done, and treatment discontinuation can be done. If there is appearance of new lesions which are 1 or 2, and if they are amenable to radiotherapy, we can target it with radiotherapy, and the lutetium PSMA cycle can be continued so that stable disease is persistent. The other radiation safety and protections, We have to advise the patient to flush the toilet for around 7 days post infusion. It can be continued. Separation of laundry and utensils for the first week. Avoid prolonged contact with pregnant women or children for 7 days. Sexual contact precautions should be taken. No breastfeeding during treatment. Ideally, it is not applicable because the patient is a male. Increased fluid intake to clear kidneys. Staff and facility requirements, designated radioactive waste disposal protocol, radiation monitoring badges for all staff, lead linen preparation cabinet for dose drawing, dedicated therapy rooms with radiation shielding, emergency spill kit should be readily available, and dosimetry records should be maintained as per local regulations. So what is the most common safety profile and toxicity management? Very common is xerostomia. It is the most common adverse effect. The taste changes, usually managed with hydration and with lemon drops. Vitamin C intake has to be increased. The most important is bone marrow. This is the dose limiting, and this may restrict the number of cycles which are given. Thrombocytopenia, anemia and neutropenia, that is pancytopenia may be there. The other one dose limiting is again kidney, which is the excretory organ. And this is the key organ for dosimetry, and we have to monitor the GFR levels as well as the creatinine levels. Amino acid infusion is optional but is given so that the load on the kidneys is reduced. The other adverse effects include fatigue, the GI adverse effects which are because of radiation, and also dry eyes because of lacrimal gland exposure. So how is the response assessment and follow-up done? Baseline usually pre-cycle, a PSMA PET CT is done. Usually chest CT, abdomen or pelvis may be part of the workup. Bone scintigraphy is also done. Usually in multiple cases, multiparametric MRI is also done at the initial stages. A clinical exam should be comprehensive, and PSA, CBC and other parameters should be assessed. After cycles 2 to 3, PSMA PET CT restaging should be done. PSA response is assessed by the decrement in PSA levels by more than 50%. A toxicity assessment should be done. After 6 cycles, a full restaging PET CT, PSMA PET CT scan should be done. PSA levels which have been plotted over the period of 6 cycles has to be assessed. Further therapy plan, and patient should be followed up at least 3 to 6 months to assess for response or for disease progression. So this is one of the few images I got from the Journal of Nuclear Medicine. We can see at the baseline the PSMA tumor volume is very high, and the PSA levels are very high. Post 2 cycles of chemotherapy, we can see significant response in the skeletal metastatic lesions. There is reduction in the tumor burden, tumor volume, as well as a significant reduction in the PSA. This is one more case with extensive disease, baseline stage 4 disease with extensive skeletal metastatic disease. Over a period of time, there is decrease in the PSA levels, and finally we can see the patient has got near complete response. So finally concluding, there are some off-label use and future directions in which the PSMA therapy is going. Now the phase 3 trials are going for PSMA4 and upfront PSMA and enzalutamide, where upfront in metastatic castration-resistant prostate cancer as well as in hormone-sensitive prostate cancers, they are trying to use lutetium PSMA therapies. Combination strategies are coming up where PARP inhibitors like olaparib or with enzalutamide in first-line lutetium PSMA is used with 2 cycles. The alpha emitters, which Sir was discussing, 225 actinium PSMA 617 is now available. In those patients who are progressing with lutetium PSMA, actinium can be a very good viable alternative, but the toxicity profile is different and the radiation exposure is higher. Certain alternative ligands are also being used. Personalized dosimetry is being planned so that the radiation exposure to the patients are restricted, and further monitoring with genomic DNA, complementary DNA and liquid biopsy is being considered to be correlated with PSMA PET CT for response assessment. So what are the key clinical takeaways? Lutetium PSMA is now FDA approved, and PSMA PET is mandatory pre-therapy as well as post-therapy in interim as well as at completion of cycles. Now the prostatic cancer has evolved into a theranostic platform where you do both diagnostic as well as therapeutics. There is standardized dosing available. The toxicity is very much manageable, and the future looks bright. Thank you.
Can you ask what you told about amino acids for prostate C? Are you really protecting the kidney or any literature?
There will be increased load on the kidneys of lutetium
But we are not giving actually.
Usually used in DOTA, but when we are treating neuroendocrine tumors, but can be used in lutetium cases.
Okay.
Thank you so much, sir. Now, I would like to request Dr. P.K. Pradhan, sir, to kindly felicitate Dr. Abhiram, sir. Okay. I would like to thank all the dignitaries, juniors and seniors, and all those people who attended these online session. Thank you for attending this academic session.